Hey everyone, my name is Ruby. I'm a fourth year medical student at Tulane. I'll be presenting a case report titled From Aplastic Anemia to Paroxysmal Nocturnal Hemoglobinuria. So aplastic anemia is a form of bone marrow failure, and normally it presents with pancytopenia and bone marrow aplasia. And it's really defined by the loss of hematopoietic stem cells. And this is thought to be a mostly autoimmune mediated process that happens via cytotoxic lymphocyte destruction of those stem cells. And aplastic anemia has a really close relationship with PNH, also known as paroxysmal nocturnal hemoglobinuria. So PNH presents with the absence of these GPI-anchored proteins, such as CD55 and CD59, on the surface of red blood cells. And this leads to complement-mediated destruction of those red blood cells. And so the case that I'm going to discuss today is a case of aplastic anemia that's transformed into PNH, and it really highlights the complexity of these two different etiologies. And this is clinically relevant because about 10% of aplastic anemia cases will transform into PNH, but because of how rare these etiologies are, it's not frequently seen. So that's why we wanted to highlight it today. So our clinical presentation was a patient who's 29 years old, who initially had presented to an outside hospital with mucosal bleeding, weakness, and pancytopenia. So at that time, a bone marrow biopsy was obtained, and it revealed a markedly hypocellular marrow. And you can see that here in figure 1. And so that was diagnostic for aplastic anemia. Patient was treated for aplastic anemia, and then 3 years following that initial diagnosis, that patient presented to our hospital with nausea, vomiting, weakness, fatigue, and mucosal bleeding again. And at this time, patient was also found to be pancytopenic. So at that time, our differential diagnosis included an exacerbation of their existing aplastic anemia or aplastic crisis, MDS, PNH, as well as different infectious etiologies. And so to kind of elucidate the diagnosis, we did a repeat bone marrow biopsy. And that repeat biopsy revealed a normo to hypercellular marrow with 1% blasts. The infectious workup was completely negative. Also completed flow cytometry at that time. And so the flow cytometry showed the presence of GPI-anchored deficient cells in 98% of granulocytes and 99% of monocytes. And so this is consistent with a diagnosis of PNH. And you can see that workup there in figure 2. So on the right side, you can see the normal clones, and on the other side, you can see the PNH clone. So in the bottom figure, you can see that the PNH clones are deficient in CD55 and CD59, just as we would expect in a PNH diagnosis. And so that's what we found in this patient. And this patient's treatment course following that diagnosis has been kind of limited by various social factors, but most recently, the patient was started on treatment with rebolizumab, which is an anti-complement inhibitor, and will continue on this therapy and has been responding well. So just to conclude the case, so this case really highlights the need for a high index of clinical suspicion for PNH in patients with aplastic anemia who are presenting with new symptoms. This can present with unexplained pancytopenia, as in our case, and instead of assuming that this is just an exacerbation of the existing aplastic anemia, it's really important to obtain confirmatory testing to really further elucidate any other possible diagnoses. And in addition to unexplained pancytopenia, PNH can also present with hemolysis or thrombosis. And that's what we can see in figure 3 is some of the different presenting factors for PNH. And so if an aplastic anemia patient presents with any of these factors, it's really important to obtain a confirmatory biopsy. And this confirmatory biopsy with flow cytometry can help us guide therapy decisions. Like in classical PNH in the setting of aplastic anemia can be treated with the anti-complement agents such as rebolizumab, and that's what was seen in our case. And there's still a lot of research going on about better ways to treat PNH that arises in the context of aplastic anemia, but just another reason why this confirmatory biopsy can be really helpful for our patients so that we can get them started on the right treatment for their PNH. And that's everything I have, if anyone has any questions.
Great. Thank you so much, Ruby. So did this patient respond well to rebolizumab?
Yeah, they initially were not responding super well, but we've now gotten a confirmatory biopsy and they clinically are doing a lot better. And so it seems to be working for them so far.